These are my disclosures, although none are really relevant to this particular presentation. The one disclosure that I do want to make is that I don't really have any connection with IRAD, but I have a friend, Santi Trimarchi, who's one of the co-principal investigators, and he was nice enough to share his slides with me, which I'm now largely going to share with you today. So IRAD is the International Registry of Acute Aortic Dissections. It was started in 1996, and we've really drawn a wealth of knowledge about aortic dissection from the IRAD experience and multiple publications. The co-principal investigators when it was started were Kim Eagle, Dr. Eisenbacher, and Dr. Nienaber. There is a total of 54 sites represented throughout the world, although concentrated mostly in North America and Europe. A total of over 8,000 patients have been enrolled to date, about 2/3 of them with type A dissections and 1/3 with type B dissections. There is a separate interventional cohort looking specifically at open and endovascular therapy of these patients. It was started in 2010, and Santi Trimarchi, who shared the slides, he's one of the co-investigators along with Dr. Patel from the University of Michigan for the interventional cohort. In the interventional cohort, they've had just over 2,800 cases that have been enrolled to date. Again, type A's are much higher representation in intervention than type B's, which represent just over 17%. We've learned a lot from IRAD over the years, and while I'm not part of IRAD, I certainly have read and learned a lot from IRAD. This is a classic slide looking at the outcomes of aortic dissection, medically treated and intervened upon, looking at acute 30-day in-hospital mortality for the most part. So we know that with type A dissections, that with medical treatment alone, the mortality is quite high from IRAD. With surgical treatment, there is improvement in the outcomes with a reduction in the mortality. So we know that the treatment of acute type A dissections preferentially is surgical. Type B, on the other hand, the behavior is a little bit different. If you look at the mortality with surgical treatment, it's around 30%. It's actually lower with medical treatment for type B dissections, and that's why with acute type B dissections, surgery is largely reserved for patients who have complicated dissections or complications like you just heard from Dr. Voyuka. Other things that we've learned is there was a later publication that suggested while medical treatment did have lower 30-day mortality for acute type P dissections and surgical treatment, that maybe that small cohort of patients in IRAD who had endovascular therapy with fenestration or TVAR might actually have a lower mortality, here at 7% in this particular publication. We also just heard from Dr. Voyuka looking at predictors. Some of that's come from IRAD as well. So the paper in the New England Journal talking about the poor outcome predictor of partial false lumen thrombosis actually came out of the IRAD group. I'm going to give you some recent updates and new information from IRAD because I thought that would be particularly pertinent. And there's so much information out there that I'm going to focus largely on type B aortic dissection, which is the topic of the current session this morning. There's been some recent work out of IRAD looking at aortic dissections in Marfan patients. We know that patients with connective tissue disorders, by and large, we still prefer open surgery. That is the case in the IRAD registry, where most patients who had intervention with Marfan syndrome were treated with open surgery for type B dissections in the IRAD group. And the mortality for open surgery in Marfan's patients is actually quite low. In the IRAD experience, it was actually 0% versus 17% in the patients who had open surgery who did not have Marfan syndrome, probably reflecting the fact that these are, by and large, younger patients than the non-Marfan cohort. There is some catch-up, but overall, these patients do well following surgery, and there's no differences in 5-year survival in patients with or without Marfan syndrome after surgery for type P dissection. But Marfan patients certainly are prone to progression of their disease and need for additional reintervention. So if you look at 5-year freedom from reinterventions, it is markedly different with a much higher need for reintervention in the Marfan population, especially in those patients treated with endovascular therapy, only 40% freedom from reintervention at 5 years. This is another recent paper from the IRAD group that looked at the question specifically is what is the outcome effect of a retrograde extension into the aortic arch of a type B aortic dissection. The incidence in the IRAD registry is about 16.5% of the type B aortic dissections. They divided patients who were undergoing intervention into Group 1, who did not have retrograde extension of their type B dissection, and Group 2 was 67 patients who did have retrograde extension into the aortic arch. There was really no difference overall in management, which I thought was interesting, that equal percentages of patients were treated with endovascular therapy, about a third of the patients with or without retrograde extension of the dissection. Most patients were treated medically, but if you look at the effect on mortality, there was really no difference observed in mortality if there was retrograde extension of the type B dissection. There was also no difference overall in 5-year survival in these patients. Now, one sub-question out of that is looking at what's the effect of a retrograde dissection, not just into the arch, but all the way into the ascending aorta. So they looked at that as well. They found that if the dissection extended all the way into the ascending aorta, as you might expect, those patients were more frequently treated with an open surgical approach. The patients who only had extension into the arch into zones 1 and 2 were more frequently treated with TEVAR than with open surgery. They did not see, also the same difference was true with medical therapy, that a lot of the ones that only extended into zone 1 and zone 2, if they were otherwise uncomplicated, were treated medically as opposed to with either surgical or endovascular intervention. They said that there was no difference in early mortality. If you look at the numbers, 18.6% versus 8.6% overall, that there probably is a trend, but it's just not statistically significant given the numbers in their experience. There's some new information. This is unpublished data, but it's been presented at meetings. They look specifically at this question that we were just addressing, the management of uncomplicated acute type B dissections, looking at should those patients be treated medically or with intervention with TEVAR. If you look overall in the IRAD registry, 90% of patients with uncomplicated dissections have been treated medically, and just over 9% have been treated endovascularly with TEVAR. There really is no difference in the survival between these two groups, which is consistent really with what we saw from the early results of the INSTEAD trial as well. Out to 5 years, no difference in the IRAD registry. If you look specifically at the question of the outcomes in uncomplicated versus complicated TEVAR for type B dissections, again, they've got a total of 280 patients who have been treated for acute type B dissections with TEVAR. 22% of those were uncomplicated. More than 3/4 were complicated, as you might imagine. That's not too surprising. Also not too surprising is there are marked differences in in-hospital mortality. There was no mortality in hospital for the patients who underwent TEVAR for uncomplicated dissections, whereas the mortality was 13.8% for complicated, and I think that's consistent with other data that's out there in the literature. Looking at procedural characteristics that were associated with in-hospital mortality for the complicated type B dissections, it was the need to place a celiac artery stent, probably for visceral malperfusion, an increased number of stent grafts deployed, or perhaps longer aortic coverage, and a larger diameter aorta indicating a larger diameter proximal graft size that was picked were associated with poorer outcomes. If we look, however, at 5-year survival and freedom from reintervention, really in those patients who underwent intervention with TEVAR, there was no real difference overall. So if you got through that acute hospital mortality risk, then your outcome was actually very good, even if you had a complicated dissection with estimated 5-year survival and freedom from reintervention that was the same as for the uncomplicated group. To wrap up here, I think it's important to note that this is a registry, and certainly there are limitations. It's retrospective, which introduces certain biases. It's an observational study in patients treated at high-volume tertiary referral centers, so it may not be totally reflective of real-world practice. The only real hard outcome parameter that's been assessed is in-hospital death, so we have to keep that in mind. So we don't know about other outcome measures like spinal cord injury and other complications. And the only follow-up information we really have is on mortality, and we don't specifically have information on cause of death. So it certainly provides a valuable platform for modern strategic planning for other trials, serves as a hypothesis-generating source of information on aortic dissections, and we've learned a lot from IRAD. If you're interested, they do have a website where they do have some of this information provided. Thank you very much.